Welcome. I am Dr. Raed Dweik, Director of the Pulmonary Vascular Program in the Department of Pulmonary, Allergy, and Critical Care Medicine at the Cleveland Clinic. I'm pleased to welcome you to the Cleveland Clinic's Respiratory Virtual Grand Rounds. These are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing patients with a certain disease. For today's presentation, I have asked Dr. Culver to provide you with an overview of the current management strategies for sarcoidosis, including evaluation and treatment. Dr. Daniel Culver directs the Sarcoidosis Center at the Cleveland Clinic and is a frequent speaker on the topic at national and international meetings. Dr. Culver earned his Doctor of Osteopathic Medicine degree at the Ohio University College of Osteopathic Medicine in Athens, Ohio. He completed his residency in internal medicine and a fellowship in pulmonary and critical care medicine at Cleveland Clinic. Dr. Culver is a fellow of the American College of Chest Physicians and a member of several professional associations, including the American Thoracic Society and the World Association of Sarcoidosis. Dr. Culver's case-based presentation includes integrated audience response questions that are designed to help you test your knowledge as you follow along. Here is Dr. Culver.
My name is Dan Culver. I'm a pulmonologist, and I run the Sarcoid Center at the Cleveland Clinic. The topic today is management strategies for sarcoidosis. We'll start off with a case study, and this is a patient who might appear in your clinic with some questions that are germane to the management. A 44-year-old male with a 6-month history of fatigue, arthralgias, and liver function abnormalities. He's a never smoker who works as an automobile mechanic. He has a history of hypertension and borderline type 2 diabetes. An abdominal CT obtained for a workup showed multiple hypodense lesions in the spleen, prompting chest imaging. You can see his PA and lateral chest radiographs show mid-lung zone predominant infiltrates with bihilar fullness suggestive of adenopathy. His PFTs show mild obstruction with a borderline low diffusing capacity. A chest CT scan is obtained showing multifocal nodular disease. The questions that would arise in a case like this germane to management would be, how confident can you be about the diagnosis of sarcoidosis? What is the prognosis? What are the appropriate tests at this juncture? And what should the treatment strategy be? So the first question is this clinical situation consistent with sarcoidosis? And the options are yes on the basis of the chest imaging pattern, yes on the basis of the splenic imaging pattern, yes, but a biopsy will be necessary to substantiate the diagnosis, and yes, if the Angiotensin Converting Enzyme level is elevated. The correct answer is number 3. Yes, a biopsy is necessary to substantiate the diagnosis. And so the first thing that we do when we're approached with a patient who has potential sarcoidosis is to carefully consider whether or not the diagnosis is correct, whether or not a biopsy is necessary, and how to best obtain a biopsy. We've noticed in our clinic that approximately 1 in 6 patients referred with a diagnosis of sarcoidosis or suspected sarcoidosis, in fact, have other causes for their syndrome. And so we're very careful to reevaluate the diagnosis. The next slide shows the American Thoracic Society and European Respiratory Society statements on sarcoidosis, showing the 3 steps necessary to establish a diagnosis. And it's important to go through each of these 3 steps when considering whether or not sarcoidosis is the cause of a clinical scenario. We'll talk about that a little bit today. The first is that there should be compatible clinical radiologic features. The second is the finding of non-caseating granulomas in most situations. And third, and most commonly missed, is the exclusion of other causes of either local or systemic granulomatous reactions. So what about the first step? What about the clinical scenario would make it typical or atypical for a diagnosis of sarcoidosis. So the next slide depicts features which would make you lean for or against the diagnosis of sarcoidosis. The more of those that are present in the left column would lead to a higher suspicion of sarcoidosis, whereas those in the right column would lead you to question the diagnosis of purported sarcoidosis. Especially important on this table, I think, are the absence of clinical symptoms. In other words, patients with hyaluradenopathy and no clinical symptoms are highly likely to have sarcoidosis. It's also not well appreciated by many that the typical finding of a complete blood count in a patient with sarcoidosis is peripheral blood lymphopenia. Many people use bronchoscopy to substantiate or at least to provide evidence for a diagnosis of sarcoidosis. And it is true that as the percentage of lymphocytes or the BAL CD4 to CD8 ratio increases, the specificity of bronchoscopy for making a diagnosis increases. On the other hand, if you look at the right column, you can see there are a number of features that argue against the diagnosis. Smoking is relatively protective, and so the odds ratio for getting sarcoidosis in a smoker is about 0.6. Exposure to other environmental agents that can cause granulomatous reactions, such as beryllium, other metal dusts, or organic hypersensitivity pneumonitis antigens would lead you to having a higher suspicion of an alternative diagnosis. History of recurrent infections or hypogammaglobulinemia should lead you to consider a diagnosis of common variable immune deficiency, which can cause a granulomatous reaction indistinguishable from sarcoidosis. And finally, it's important to consider that a number of systemic diseases may also lead to granulomatous reactions that can mimic sarcoidosis. After you put all these clues together, you consider whether or not there's enough evidence to go forward with making a diagnosis. And so the next slide depicts one algorithm that's been proposed for making a diagnosis and assessing sarcoidosis. And it starts with the suspicion of the disease. There are a few situations that are pathognomonic for sarcoidosis in the right clinical context, and those include Lofgren's syndrome, which is characterized by erythema nodosum, bihilar adenopathy, typically constitutional symptoms, and sometimes periarticular arthralgias. There are also some other syndromes, such as isolated bihilar adenopathy or uptake on a gallium scan in the lacrimal glands, parotid glands, and thoracic lymph nodes, the so-called panda lambda sign, which would allow a confident diagnosis of sarcoidosis in the absence of alternative easily discernible causes without a biopsy. However, most patients will require a biopsy, and so the biopsy can be targeted to the area that is the most accessible. In clinical practice, this usually means the skin, a peripheral lymph node, or the lungs. And in the lungs, there are a number of places to target for biopsy. So the next slide has the next question, and that is, all of the following may confirm the clinical suspicion of sarcoidosis except, number 1, endobronchial forceps biopsy of the mucosa, number 2, skin biopsy of the erythema nodosum lesion on the shin, number 3, a transbronchial needle aspiration of a partially calcified hilar lymph node, and number 4, transbronchial lung biopsy in a patient with enlarged hilar lymph nodes but no parenchymal disease on high-resolution chest CT. The correct answer to this question is number 2. A skin biopsy of erythema nodosum lesion will reveal only a paniculitis but no granulomas, and so the diagnosis of sarcoidosis cannot be confirmed. All the other biopsy techniques have an appreciable yield, including even patients who have no evident parenchymal disease on their chest CT and yet have some strong clinical suspicion of sarcoidosis, perhaps affecting the eye or the central nervous system. There has been an evolution of biopsy targets in the last few years, and the next slide depicts an image from an endobronchial ultrasound, which can be used for guided TBNA biopsy of very small lymph nodes, ones that might have been inaccessible to past techniques. In many centers, EBUS TBNA is replacing mediastinoscopy as the gold standard for diagnosis of sarcoidosis. It is apparent that this outperforms conventional blind TBNA. There are several trials recently suggesting that it outperforms transbronchial biopsies as well, and the safety record of EBUS TBNA is excellent. It should be noted, however, that there are some issues with EBUS TBNA. One of those is the expertise of both the operator and the reader. The second is that a finding of a granuloma in a lymph node may or may not reflect the true pathology that's causing symptoms or infiltrates on a chest imaging. And so it's very important that the person who's interpreting the results of an EBUS TBNA be very circumspect about what the results of a granuloma seen on EBUS mean in the context of the patient, remembering that the diagnosis requires best compatible clinical radiologic findings. And if the physician is suspicious that a different diagnosis is in play, despite a positive EBUS TBNA, they may very well be right. The next slide depicts a table from the ATS statement on sarcoidosis, just showing the differential diagnosis of granulomas in various organ systems. And the point of this is that there is a wide differential diagnosis for granulomatous inflammation, and all of these things need to be considered when making a diagnosis of sarcoidosis. If one thinks about compatible clinical radiologic features of sarcoidosis, imaging patterns often can be quite helpful. The next image depicts a typical chest CT seen in sarcoidosis, and the salient features to note are that there are some partially calcified lymph nodes in the mediastinum, not very well appreciated on this image, but also that there are innumerable micronodular infiltrates that follow a lymphatic distribution. That is, they predominantly are along the bronchovascular bundles, and they may also involve the pleural area, including the interlobar fissures. And when you see micronodular infiltrates in that sort of distribution in the right clinical setting, the diagnosis of sarcoidosis becomes quite likely. As I mentioned before, it's important to think about other causes of granulomatous inflammation, and the next slide depicts two of the general categories of causes that are commonly mislabeled as sarcoidosis. The first of those is single-organ granulomatous syndromes. These may be seen in areas of wounds, like on this scar sarcoidosis that occurs in an area of prior trauma. These may also be seen in areas that are draining certain regions, such as in axillary lymph nodes or in porta hepatis lymph nodes. Another common cause of misdiagnosis is sarcoidosis-like reactions. And the image on the right depicts a pulmonary adenocarcinoma, which is revealed by the red arrow, with an overlying granulomatous reaction, which is revealed by the yellow arrow, which was first misdiagnosed as sarcoidosis after an endobronchial forceps biopsy. So again, the management of sarcoidosis requires careful consideration of potential mimics before embarking on labeling a patient with sarcoidosis and moving forward with treatment strategies. On the next slide, we come back to having made a diagnosis, having considered mimics and documented multisystem organ involvement, and then the next step is to assess the extent of the disease and the severity of the disease, both to guide follow-up as well as prognosis and treatment. When you think about assessing sarcoidosis, it is often questioned how active is the disease, and the term activity has many different definitions in the literature. Some people refer to that as being the degree of organ dysfunction, whereas another axis of activity could be the degree of clinical progression. This would imply that the patient would need to be followed over time to document activity. And a final axis of activity could be the degree of immunologic derangement as measured by any kind of proposed cytokines or various other laboratory tests which are supposedly linked to the degree of inflammation. As a broad concept, I would say that none of these immunologic derangements are sufficient in and of themselves to guide treatment decisions, but could more generally be used in order to ascertain whether or not symptoms are related to active inflammation. And so, in order to assess sarcoidosis, the general concept is to have a very basic, complete assessment of common organ involvements. So the next slide demonstrates the suggested baseline evaluation for patients at the time of diagnosis of sarcoidosis. You can see that many of the tests listed here are quite basic. Very few of them are very expensive. The EKG and ophthalmologic exam are standard, at least at baseline. Whether or not those need to be repeated intermittently is a subject of some controversy, but in our practice, we are very symptom-guided after the initial assessment, and so we do not typically repeat those things unless something new happens. You'll also notice that the newer imaging tests, such as PET scan, are not included here. And the reason for that is that we do not treat the presence of sarcoidosis, but we treat clinically bothersome sarcoidosis, except in the case of some organ involvements that we'll get into later. So if you think about assessing the activity, one of the things that comes up quite commonly is the role of the Angiotensin Converting Enzyme level. The next slide asks the question of what is it useful for? And the answers are, number one, is it supportive of active granulomatous inflammation? Number two, it has a high specificity for the diagnosis of sarcoidosis. Number three, the level correlates with the disease activity. Or number four, the level correlates with the extent of the disease in genotype-corrected African Americans. And the correct answer to this is number one. Presence of an elevated angiotensin converting enzyme level does suggest that there is active granulomatous inflammation if there are no other causes for it evident, but it lacks adequate specificity or correlation with disease activity to make a diagnosis or to make management decisions on. The next slide demonstrates one study that looked at two biomarkers of disease activity. This is the angiotensin converting enzyme level and the soluble interleukin-2 receptor level. And they asked whether or not these levels correlate with abnormal PFTs, listed here as respiratory function impairment. The left-hand panel shows patients either requiring or not requiring treatment, and you can see that the angiotensin converting enzyme level does not stratify those patients very well. On the right-hand panel, you can see that the soluble interleukin-2 receptor level does seem to stratify to some degree which patients have abnormal pulmonary function tests, but there is very substantial overlap between the groups. And so again, this cannot be used in isolation as a rationale for treatment. It's also important to remember when thinking about prognosis and management decisions that most patients with sarcoidosis will have resolution of their disease. And so the next slide demonstrates the rate of chest radiograph resolution in 4 series in the Northern European and Japanese centers over up to 5 years after the time of diagnosis. While these data don't necessarily reflect what happens in all ethnicities and locations, it's true that between 1/3 and 2/3 of patients with sarcoidosis will have resolution of their disease sometime in the first 5 years after the diagnosis, whereas if the disease persists after 5 years, the likelihood of resolution is substantially lower. It should also be noted, if you look at larger sarcoidosis centers, that even persistence of disease after 5 years does not necessarily indicate progressive or clinically bothersome disease, and that a high proportion of patients will have persistent but not particularly bothersome disease after a period of some years. One of the other tools that's been used for assessing prognosis is the Scadding radiographic staging system. This is a system that was proposed about 50 years ago in the United Kingdom, and this is a way of relating chest X-ray to the likelihood of spontaneous resolution within the first 5 years after the diagnosis. You can see depicted here, based on the chest X-ray from stage 1 to stage 4, the likelihood of a resolution of the X-ray itself within 5 years after the diagnosis. It should be noted that the scadding stages do not necessarily correlate with extrapulmonary disease. They are not necessarily indicative of response to therapy. They do not necessarily have validity for chest radiograph, and that patients do not progress serially from 1 to 2 to 3 to 4. These are all misconceptions that patients often have, and that can be allayed at the time that you talk with them. Another thing about the chest X-ray is that it has a very poor correlation with either the symptoms or with the pulmonary function tests. And the next slide just demonstrates the poor correlation graphically in a patient with excellent function and very well-preserved pulmonary function tests on the left, yet a very advanced chest X-ray, versus a patient on the right who is quite dyspneic and who has very poor pulmonary function tests, yet has only a stage 1 chest radiograph. Besides the radiograph, there are other features which seem to correlate with a poor prognosis, and based on a variety of studies, the table here lists a number of the features which have been most consistently found. Some of these are demographic, that is age and race. Very strong feature of prognosis is the requirement for therapy. In other words, once you get on the pathway to needing therapy, it's highly likely that you will need ongoing therapy. And then the presence of a number of features of extrapulmonary involvement or specific aspects of pulmonary involvement also predict the likelihood of requiring ongoing therapy or having persistent bothersome disease. If you look just at pulmonary disease, as is done in the next slide in an case-control etiologic study of sarcoidosis, you can see how important the need for therapy up front is. And so the graph demonstrates that patients who are not treated within the first 6 months, which is the left-hand bar, very rarely need treatment. Those would be the blue-colored patients, whereas patients who need early treatment in the first 6 months, at a 2-year time point, almost half of those require ongoing therapy. In that study, the only independent predictors of ongoing need for treatment at 2 years were either the need for treatment early on or higher levels of dyspnea. Things that have been thought to be independent predictors in the past, such as race, age, gender, or pulmonary function tests, were not important in this analysis. If you think about treatment, you may wonder what the goal of it is, and I think it's very important that you think about what the goal is before initiating treatment. So the question is, on the next slide, which of the following would be expected with corticosteroid treatment of sarcoidosis? Number 1, improvement of the FVC by 10 to 15%. Number 2, improved likelihood of remission. Number 3, prevention of other organ involvement. Or number 4, none of the above. The correct answer to this question is none of the above. We'll go through some of the data behind that, but in fact, the magnitude of pulmonary function test improvement after a trial of corticosteroids tends to be more in the range of 5 to 10% for either FVC or DLCO, along with some improvements of the radiograph. Whether or not those are durable is unclear, but it seems unlikely that without ongoing treatment that those gains are necessarily maintained until the disease actually goes into remission. It's also important when thinking about medical therapy for sarcoidosis to consider the cause of the patient's symptoms. Patients very rarely care about the forced vital capacity or the chest X-ray. Instead, they're much more interested in how can I get by in my daily life and what are you going to do about my symptoms? If you think about pulmonary sarcoidosis, dyspnea tends to be the most common symptom. The next slide demonstrates some of the differential diagnosis of factors that are important in the development of dyspnea in sarcoidosis patients. And you can see that all of these would require different diagnostic and potentially different management approaches, including deconditioning, bronchospasm, which can occur in up to 21% of sarcoidosis patients, pulmonary hypertension, which is quite prevalent in chronic sarcoidosis patients with significant dyspnea, the presence of myopathy, which could be an effect of the sarcoidosis or of steroid therapy, obesity, anemia, and finally cardiac sarcoidosis, which probably occurs in 5% of patients with sarcoidosis clinically, but may be underdiagnosed in patients with chronic dyspnea. Besides pulmonary sarcoidosis, there are a variety of other complaints that patients note, and the next slide demonstrates what we call the Sarcoidosis Penumbra. Those are issues that patients come into the clinic describing. These include fatigue, pain, and dyspnea. And you can see listed here are a number of features that contribute in the sarcoidosis population to these sorts of symptoms. Optimal management of the sarcoidosis patient from a global perspective requires thinking about all of these things. In thinking about treatment, it's also important to consider that the treatments are not necessarily benign. The next slide demonstrates the effect of steroids on the quality of life. And the authors in this particular study looked at two indices of quality of life, the St. George Respiratory Questionnaire, which is a pulmonary-specific quality of life metric, and the SF-36, which is a more general quality of life metric. If you just look at the adjusted score, you will see that the quality of life, even after controlling for a number of confounding variables, is lower in steroid users, either for St. George or for the SF-36. This slide is a little confusing because these two scales go in opposite directions, but suffice it to say that these are beyond the minimal clinically important difference for these particular scales, suggesting that the effects of the therapy might be just as bad as the disease itself. Another issue that comes up is whether or not steroids or other therapy will improve the prospects for spontaneous resolution. And I think the best study to address this question was a trial done by the British Thoracic Society over 2 decades ago now. And the next slide demonstrates the strategy of this study. And these were patients with stage 2 or 3 chest x-rays, hence with lower likelihood of spontaneous resolution. And these were observed immediately for 6 months in order to weed out the patients who definitively improved or definitively progressed early on. Those are not the patients in whom we typically struggle with treatment decisions. At the end of 6 months, there were 58 patients with stable disease, and these were randomized, alternately treated to either prednisolone or as-needed treatment with a goal of maximizing the radiologic improvement. And so the therapy was individualized on a per-patient basis. You can see that the therapy in the upfront treatment arm was relatively aggressive insofar as they were treated for 18 months. The next slide shows the results of the British Thoracic Society study. You can see the long-term treatment group was almost all treated, whereas in the as-needed group, only about 1 in 5 patients deteriorated enough to need treatment. This supports what we talked about earlier, suggesting that patients who do not need treatment in the first 6 months are quite unlikely to need treatment at any time. If you look at the 5-year follow-up, you can see that there are improvements in the vital capacity in both groups, perhaps slightly greater in magnitude in the long-term treatment than the as-needed treatment, and the same thing with the dyspnea grade. But I think that most would feel that the magnitude of these changes is relatively modest, and so still the standard practice is to observe patients who do not have immediate upfront indications for treatment for pulmonary disease. In terms of extrapulmonary disease, there are some indications for immediate treatment, and the next slide demonstrates some of those. That is active neuromuscular or cardiac disease, symptomatic hepatosplenic involvement, significant hypercalcemia, ophthalmologic disease that's refractory to topical steroids or for whom the topical steroids are causing substantial problems, and finally severe dermatologic disease. All other indications for treatment really need to be considered in the context of the course of the patient and the impact of the manifestations on the patient's quality of life and the particular organ. Now, one of the problems with corticosteroids has been that they cause substantial side effects. Some of those may be a result of use of too high doses of corticosteroids. The next slide shows the effects of treating the lung with corticosteroids. The left-hand panel shows the rate of improvement of vital capacity in patients treated with corticosteroids on a per-day basis. And this demonstrates that most of the improvement that can be seen is seen relatively early, in 3 to 4 weeks. On the right-hand slide, there are data supporting a similar point. That is, with very low doses of steroids, that you can have substantial improvements in vital capacity after a relatively short period of time. These sorts of observations lead to an approach that's depicted in the next slide, and this is an algorithm for treatment of pulmonary sarcoidosis. It's a very symptom-driven algorithm. If you start from the top, you can see that in patients with milder symptoms, that observation alone is completely reasonable, whereas if the symptoms are more severe, or in the case where there's substantial progression over time in the pulmonary function tests or the radiograph, then a relatively low dose of corticosteroids is used for a relatively short period of time, with attempts to taper in patients who have a good response. The usual threshold for maintenance therapy with corticosteroids is 7.5 to 10 milligrams a day, which is then maintained for a number of months. If there's inefficiency of that, or if the patient is unable to taper off or develops significant side effects, then a steroid-sparing therapy is often considered, and you can see those listed there. So what are the options for steroid-sparing or steroid-refractory sarcoidosis? The next slide demonstrates some of the treatments that have been used for treatment of sarcoidosis since it was first described. And you can see that there are now a wide range of choices that have been described and are actually used clinically. If you look at the options circled by the red ovals, these are the options which we use most frequently in our clinic. It's important to realize that there are no head-to-head controlled trials looking at which of these options is the best, and so quite often trial and error is the best way to determine which agent should be used for your particular patient. Some of these agents are more of historical interest, such as chlorambucil and thalidomide, whereas others are only now being explored, such as rituximab and golimumab. Suffice it to say, however, that there is a movement away from corticosteroids and towards some of these other agents in terms of toxicity. When considering the choice of initial therapy, it's important to consider the chronicity of the disease, the prognosis, the manifestations, and their expected response to therapy, as well as the patient's comorbidities. In patients with a relatively short expected duration of needed treatment and relatively fewer comorbidities, corticosteroids would be more favored, whereas in patients with comorbidities that would be worsened by corticosteroids or higher likelihood of prolonged or aggressive treatment, it might be ideal to start with corticosteroid-sparing agents early on, perhaps in conjunction with an initial corticosteroid burst. In terms of which corticosteroid-sparing agent to use, as I stated, there are very few data available. One recent study looked at a comparison just on an observational level of methotrexate versus azathioprine. These were done in 2 centers in Northern Europe. You can see by looking at this data that the vital capacity and diffusing capacity for both methotrexate and azathioprine is relatively improved similarly with both agents, given the caveats of this being observational and done in 2 different centers. However, on the bottom left panel, you can see that the patient intolerance and side effects were slightly higher with azathioprine than with methotrexate. Nonetheless, the bottom right panel depicts similar corticosteroid-sparing efficacy of both agents. So I think the point of this is that you may be able to try different cytotoxic agents and assess whether or not they are effective and tolerated in your patient before moving on to the next thing. I should also note that the time to response for any of these agents may be somewhat lengthy. Methotrexate has been said to require up to 6 months to take effect, and azathioprine and leflunomide may take several months as well. The data for mycophenolate are very sparse right now, and it is unclear how quickly that agent might work. The next slide demonstrates some data suggesting the response to leflunomide may be similar to that for methotrexate and azathioprine. Again, these are observational data looking at the slope of change in forced vital capacity and diffusing capacity in patients with pulmonary sarcoidosis, suggesting that patients who have deteriorating pulmonary function tests who are then placed on leflunomide are not just stabilized but actually improved with this agent. The corticosteroid-sparing effects of leflunomide were similar to what was seen with methotrexate and azathioprine. However, none of these agents has been the subject of a randomized controlled clinical trial in chronic pulmonary sarcoidosis. The only agent that has been tested in chronic refractory pulmonary sarcoidosis is Infliximab, and that's depicted on the next slide, where this is the only medicine that's been proved to be effective in a double-blind, randomized, placebo-controlled trial. I should note that of the biologic agents, the TNF antagonists are the only ones that are in widespread use currently, and that of the TNF antagonists, it is only the ones that are not soluble receptor constructs which seem to be effective for sarcoidosis. Of those, Infliximab has the most widespread use because of a longer track record and more demonstration of efficacy. Here you can see the results of 2 trials of Infliximab looking at the response to vital capacity after treatment with Infliximab compared with placebo. And you can see in the first study, the Bothman study, that the effect in all patients is only about 2.4% improvement in the vital capacity. These were patients who were already on multiple other immune-suppressing agents. And in fact, if you look at subsets of that group, that is patients with more severe impairment of vital capacity, higher dyspnea scores, more chronic disease, and worse quality of life, you see increasing improvements in vital capacity. Another study that was done around the same time by Dr. Rossman's group also showed improvements in a statistical and perhaps a clinically significant level in the vital capacity after treatment with Infliximab. So in practice, Infliximab is commonly used in patients who have either severe disease in whom quick control is warranted, or who have disease that's refractory to other agents. The last question that comes up with regard to treatment is the duration of treatment. In general, patients who have had more recent onset of therapy can be treated for relatively shorter periods of time before attempts at tapering, and for pulmonary disease that may be on the order of 6 to 12 months. In patients with more chronic therapy, it's important to continue to try tapering them periodically, but those attempts can be less often and more gradual. And so, in fact, you can see in this image depicted in the left-hand side of this slide that if you treat long enough until the disease actually quiets down or burns out, that you may actually believe a medication is effective, as in therapy A, whereas if you taper off a medication before the disease burns out, you may actually believe that therapy was ineffective, as in therapy B. And so, in fact, repeated trials of tapering are the only way to sort this out. An analogy I often like to tell my patients is on the right, and that is that the sarcoidosis is like a fake birthday candle. As long as you're blowing on it, it looks like it's out, but as soon as you stop blowing, it comes back on again. And the sarcoidosis will last only as long as that candle is long. Patients seem to grasp that and understand what the strategy is for our therapy. So in conclusion, in terms of managing sarcoidosis, the points I've tried to emphasize in this talk are, first, to consider the diagnosis, and that is to consider what is the easiest way to make the diagnosis. In many situations, that may be endobronchial ultrasound nowadays. And then to reconsider whether or not the diagnosis is correct based on a combination of clinical radiologic features, a biopsy that's consistent with sarcoidosis, and the exclusion of alternate causes of granulomatous syndromes. Once that has been done, then it's important to assess the extent of the disease and determine what the goals of management are. And those broadly can be either prevention of organ damage in patients who have documented progression in important organs, or improvement of quality of life with a careful balancing of the side effect of medications versus the expected benefits of them. If one is going to use immunosuppressive therapies, it's important to consider that steroid-sparing options are increasingly becoming the norm, and these can be used comfortably even early on in the diagnosis with expected benefits from a range of them. Thank you for joining us today.
Thank you very much, Dan. In this case-based presentation, Dr. Culver discussed when to suspect sarcoidosis and the importance of tissue biopsy in establishing the diagnosis. He introduced the role of endobronchial ultrasound in guiding bronchoscopic evaluation in this disease and emphasized the importance of making the correct diagnosis before initiating therapy. Dr. Culver also discussed the importance of considering goals of therapy, including end organ damage and quality of life, and reviewed the use of corticosteroids and the role of alternative steroid-sparing medications in sarcoidosis. I hope that you found Dr. Culver's presentation on sarcoidosis to be a useful update on this topic and that it would help you with the day-to-day management of patients with pulmonary as well as extrapulmonary manifestations of this disease. Finally, on behalf of myself, Dr. Culver, the Respiratory Institute, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.